Hello, and welcome to the MarylandEMS Protocol Base Station Updates. First, I would like to thank you for taking a few minutes of your time to learn about our protocol updates for 2023. The EMS base stations play a critical role in our system by delivering online medical direction to EMS clinicians in difficult cases. Before we discuss this year's updates, I would like to take a moment to cover a few brief points. First, Maryland's EMS protocols are updated annually. The additions and changes for each year go into effect on July 1st. Second, this update focuses only on the additions and changes to the statewide treatment protocols. We have several optional supplemental and pilot protocols that jurisdictions may take on. The jurisdictions and their medical directors provide additional training, equipment, and ensure thorough review and medical oversight. We will not cover these during the current presentation. However, EMS agencies and base stations should stay in close communication so that they know if a given county is participating in any OSPs or pilots. Now we will move on to the protocol updates for 2023. As you can see, there are 9 significant changes to the EMS protocols this year. I've grouped them into a BLS and ALS as well as ALS only columns here. We'll take a look at each area briefly, one by one. One change this year involves the communication section of the General Patient Care Protocol. We're drawing a careful distinction between hospital notification and medical consultation. This is because we want to ensure that the purpose of the EMS call is clear. Notification is a brief communication to the ED in order to convey information about an inbound patient. At minimum, notification is required for all incoming Priority 1 and 2 patients as well as all specialty alert patients using the EMRC recorded line. Specialty alert patients include stroke, STEMI, trauma, hand, eye, and burn patients, to name a few. For all other Priority 3 patients, EMS may either use EMRC or local radio to provide notification. You should expect to receive, at minimum, the patient's age, chief complaint, priority, clinician impression, pertinent signs and symptoms, vital signs, and ETA. For specialty patients, additional information should be relayed. For trauma patients, this includes trauma category and mechanism. For stroke patients, this includes a last known well time as well as specific neurologic findings and a LAMS score if the Cincinnati Stroke Screening Scale was positive. For STEMI patients, this would include a 12-lead EKG interpretation and duration of the patient's symptoms. Additionally, a 12-lead EKG should be transmitted to the receiving cardiac interventional center. Consultation, on the other hand, is a bidirectional communication between EMS and an authorized base station physician for the purpose of seeking guidance when an EMS clinician reaches the end of their treatment capability or obtaining guidance when required by a specific treatment protocol. Consultation can be obtained at any time for any reason. This change impacts commercial services that do interfacility transfers. Previously, many hospice and palliative care patients required critical care or SCT transport services due to having certain medical devices. However, hospice and palliative care patients do not wish to have an escalation of their level of care. Additionally, these devices rarely require any actual critical care interventions during transport. So in order to better match patients with appropriate commercial resources, we've made the following changes. For patients who are enrolled in or being transported to hospice and palliative care, the following apply. Patients who are receiving locked, continuous IV infusions may be transported by BLS. It is understood that the BLS clinician will not be expected to adjust, manipulate, or troubleshoot the IV infusion in any way. ALS clinicians may transport hospice patients who have chest tubes and those on ventilators with stable settings. For pediatric patients, the high-performance CPR algorithm has been moved from an appendix forward to the primary cardiac arrest page 3.4-P. Additionally, we have added an age-based epinephrine dosing chart. The goal with this addition is to reduce the time it takes to deliver the first dose of epinephrine during a pediatric cardiac arrest. Based upon evidence contained in the latest AHA recommendations, we have adjusted the ventilatory rate as follows. For patients less than 13 years of age, we will ask EMS clinicians to deliver 1 breath every 3 seconds, and for patients 13 years of age and older, we will deliver 1 breath every 6 seconds. There are multiple changes to the trauma decision tree algorithm this year. Changes to some of our clinical criteria were made based upon national guidelines for field triage of injured patients. However, we did not adopt all of the national guidelines in block. We will maintain category Alpha, Bravo, Charlie, and Delta, and we will also maintain the recommendation that EMS transport patients to the closest appropriate trauma center. For category Alpha, there are 4 primary changes. The first change is that we will ask the EMS clinician to measure the motor GCS score as opposed to the total GCS score. If the motor GCS score is less than 6, this patient meets category Alpha criteria. In other words, if the adult patient has a significant traumatic injury and cannot follow commands, they would now be a category Alpha. We've also added age-specific blood pressures into category Alpha and broken them out into the following age groups: under 10 years of age, 10 to 64 years of age, and 65 years of age and older. This takes into account that patients in the 65 and older age group will typically run a higher baseline blood pressure. The next change is that we've added the shock index in a simplified form. If the patient's heart rate is greater than their systolic blood pressure, they are a category Alpha. And finally, patients with a pulse ox of less than 90% who are not hypoxic at baseline or on supplemental oxygen would also meet trauma category Alpha criteria. For category Bravo, we have added a new criterion, and that is active bleeding requiring a tourniquet or wound packing with continuous pressure to achieve hemostasis. We have modified a second criterion. Previously, we said paralysis was a criterion to be a category Bravo. This has been broadened to include any patients with a suspected spinal injury who have either a new motor or sensory deficit. For category Charlie, we've added unrestrained children, 9 years of age or younger, as a criterion. And previously, there were different heights for fall patients based upon their age. This has been simplified so that now any patient who falls from a height greater than 10 feet will be a category Charlie patient. We've also added the need for extrication for patients who are pinned in vehicles to category Charlie. Importantly, this does not include routine door pops. The patient has to be entrapped to the point that they are unable to move in the vehicle. We've added a visible seatbelt sign as a category Charlie criterion. And finally, we've added any rider separated from a vehicle, whether it is a motorcycle, ATV, car, horse, or watercraft, who experiences a significant impact will be considered a category Charlie patient as well. Finally, for the category Delta criteria, we've added low-level falls in young children 5 years of age or younger with a significant head impact. Well, what do we mean by a significant head impact? If the child has altered mental status, prolonged loss of consciousness, seizures, a non-frontal hematoma, or vomiting after the fall, these should all be considered by EMS clinicians as indicators of a significant head impact. Ground-level falls may also produce serious injury in some patients, particularly those 55 years of age and older. We ask that EMS assess these patients individually and consider this fact when triaging the patient to the local ED versus a trauma center. Switching gears back to medical patients, for atrial fibrillation with rapid ventricular response, we have added a minimum required heart rate of 130 for the use of diltiazem. Clinicians may only use diltiazem if the patient has a heart rate greater than 130 and a systolic blood pressure greater than 100. Also, we've added guidance for EMS clinicians to recall that atrial fib can occur by itself or due to a secondary cause, such as sepsis or infection. In the latter case, we would want EMS to first treat the underlying cause. For example, in the case of sepsis, we would want them to focus on giving IV fluid as opposed to going right for the diltiazem. ALS clinicians have long been familiar with diltiazem. Commercial services also have the capacity to train ALS clinicians on the use of infusion pumps for transport. So for interfacility transports, qualified CRTs and paramedics may now transport adult patients on continuous diltiazem infusions. The infusion must have been initiated by the sending facility, and the rate may not exceed 15 milligrams per hour. Again, we believe this will allow patients to be matched with the most appropriate interfacility transport resource. We've added low-dose ketamine as an option for pain management if the patient requires transcutaneous pacing or synchronized cardioversion. Maryland's EMS system has used ketamine at low dose for over 5 years. This allows a pain management option that has less risk of reducing the patient's blood pressure. Notably, the dosing remains unchanged, 0.2 milligrams per kilogram IVIO slowly over 2 minutes with a maximum single dose of 20 milligrams. A repeat dose may be given in 5 to 10 minutes if needed. If an IV is unavailable, dosing is 0.5 milligrams per kilogram intranasally or intramuscular route, which may be repeated 1 time in 15 minutes if needed. The other options for sedation or pain control remain, which include midazolam or fentanyl. Finally, we've added postpartum hemorrhage as an indication for tranexamic acid or TXA this year, based upon recommendations in the medical literature. If the patient has a systolic blood pressure less than 90 or a heart rate greater than 110, and she is within 1 hour of delivery, and there's ongoing blood loss despite performing uterine massage, then the patient may receive 1 gram of TXA in 100 mLs IVIO over 10 minutes. In closing, I'm grateful for your support of the MarylandEMS system. Hospital base stations play an essential role within our system, and thank you for taking your time to learn about our protocol updates for 2023.